Our research focuses on the inadequate funding in the Indian health services and its impact on access to care among Native American and Alaskan Natives. So this is an important issue that's in dire need of discussion and reform due to the restrictions of funding within the IHS services. So the Indian Health Service, more commonly referred to as the IHS, is a government agency under the U.S. Department of Health and Human Services that's primary goal is to provide health coverage to Native American and Alaskan Natives who live on trust land or reservation areas. And so our health policy issue focuses on how the U.S. has broken their promise due to the chronic underfunding of federal programs within the IHS. And although there have been provisions within policies, there are still barriers to access of care and quality care that should be reformed so that the Native American and Alaskan Natives' health aren't suffering.
So, historically speaking, there have always been cultural differences between American Indian and Alaska Native communities when compared to the general population of the U.S. Some key factors found in American Indian and Alaska Native populations include economic, social, environmental, and lifestyle determinants. These determinants are enhanced by barriers that limit access to care. American Indian and Alaska Native individuals residing in urban areas have more restrictions when accessing care due to scarce IHS resources in cities. This particular table for Figure 1 portrays age-adjusted mortality rates per 100,000 people and highlights many disparities among health outcomes when compared between American Indian and Alaska Native populations and all other races of American citizens. For Figure 2, this particular chart illustrates funding allocations to third-party collects as well as IHS programs. It highlights just how little funding is given directly to urban health programs for Indians. And then lastly, for Figure 3, this graph indicates statistically significant differences in health outcomes between American Indian, Alaskan Native populations and white populations.
For discussion, policies and legislation have been established to address issues the Native population faces under the IHS. Since 1954 to the present day, facilities under the IHS have been under supervision and have transferred responsibility with the creation of policies that improve their health status over time. Even though provisions have been implemented, the IHS underfunding is still an issue because there is a limited amount of money given to the IHS and lack of equitable distribution of resources within the IHS programs, and this negatively affects direct health service delivered to the Native population.
So moving on to some conclusions we found while assessing our research was that an issue in the IHS is that it does not cover all Native American reservations, which may cause many individuals to lack access to care. Also, insufficient funding also causes economic issues that result in poor quality and poor access to care. Without appropriate care, American Indian and Alaska Native populations suffer higher rates of mortality due to chronic illnesses that could have been prevented. So for our recommendations with these policy issues, first off, we would expand Medicaid to all states within the nation to provide coverage for uninsured American Indian and Alaskan Native individuals. Second, American Indian and Alaskan Native awareness would be implemented through education to minimize any barriers experienced when accessing health care. And lastly, increased levels of health literacy among American Indian and Alaska Native populations through primary care providers would appropriately and properly help in delivering quality health services to these populations. Lastly, for public health implications, we would work to improve health surveillance, assess awareness of health challenges in American Indian and Alaska Native communities, identify health disparities among American Indian and Alaska Native populations, and create intervention programs to meet these needs, and lastly, to assure cultural and language understanding when administering care to American Indian and Alaska Native populations. We would like to acknowledge and thank the Austin College Public Health Department and Dr. Kuko's guidance during this research process.